Hello, and you're very welcome to this broadcast about physical activity, exercise and osteoarthritis. I'm Gráinne O'Leary, Chief Executive of Arthritis Ireland. I'm delighted to be joined today by Andy Dunne. Andy is a chartered physiotherapist and owner of Personal Health, a lifestyle healthcare company. Andy has worked extensively with people living with osteoarthritis and with patients post-knee and hip replacement. So osteoarthritis is the most common form of arthritis, affecting millions of people worldwide and thousands of people here in Ireland. It can affect any joint in the body, but it commonly affects the weight-bearing joints of the knees and hips. Although there's no cure for osteoarthritis yet, there are treatments that can provide relief from the symptoms and allow you to get on with your life. Physical activity and exercise is one of those areas which we are going to explore further today. So Andy, I'll start by asking you, is there a difference between physical activity and exercise?
Yes, I would say explicitly there's a difference. The World Health Organization make very explicit reference to there being that difference, and it's measurable. It's low-level physical activity would be considered your day-to-day activities. You're walking up and down the stairs, throwing on a wash, hanging up clothes, cooking food. They're your activities of daily living. They're very appropriate and beneficial, but they're not considered formal exercise. When you start to differentiate really around exercise, you're talking about heart rate parameters, getting into a certain heart rate zone through your exercise. And then there are different zones: low level, moderate, vigorous. So there are definitely key differences around physical activity and exercise. And the recommendations have recently been changed in that optimal exercise per week is 75 minutes and optimal physical activity levels is 150 to 300 minutes, which is quite a gap. But there's some key differences there between the two.
Okay. And like in general terms, what are the benefits of physical activity and exercise?
I suppose in general terms, physical activity has multiple benefits, from getting through the little tasks we all need to get through every day to just keeping us in some way active, improving circulation, appropriate usage of our muscles as opposed to being sedentary. In terms of then the benefits of exercise, I'm clearly very biased towards this, but if there was a tablet that could do the benefits of exercise in one go, it would be a $1 billion tablet in terms of pharma companies. So in terms of the health benefits of exercise, we're talking about improvements in bone density, improvements in lean muscle, improvements in circulation around a joint, whether it's problematic or not. We're talking about improvements of heart function, lung function, internal organ function, cognitive benefits, improvements in your mood, improvements in your quality of life, your happiness. They are many and varied, but they are hugely positive influences if you can get the right dosage of exercise into your life.
Yeah, huge list there.
Yeah.
And when it comes to osteoarthritis, what are the benefits?
So in particular, I think people there are clearly, as you referred, there are millions around the world with osteoarthritis, and there are thousands in Ireland, and every person dealing with osteoarthritis has, I suppose, their own unique profile, their own physique, their own height, their own weight, their own medical history, and their own, I suppose, their own history away from the medical side of things leading up to maybe the injury or how they acquired osteoarthritis. So if you take those factors into account, there's a lot of variables to be one-size-fits-all prescriptions in exercise. However, one of the most overriding and obvious factors that benefits an arthritic patient, osteoarthritic patient, is strengthening the soft tissue structures around the osteoarthritic joint. So while we can't cure osteoarthritis, we can't necessarily reverse the deterioration in bone quality. We can vastly improve everything that surrounds it. I often refer to it as scaffolding for people, that they can really build quite significant amounts of strength. And in order to see small improvements, you're talking initially probably 6 weeks before you start to see positive changes around strengthening an arthritic joint. So if I was really trying to focus on one area or one beneficial area of exercise for osteoarthritis, it's the strengthening factor more than anything that seems to have a huge benefit.
And just as a lead on to that, you mentioned strengthening exercises, but are there there's lots of different types of exercise, lots of different types of exercise programs, but are there types that are best for osteoarthritis, or are there particular forms that are better, depending on the joints that are affected, for instance?
Yeah, I think, again, from a clinical point of view, we work around the mantra that exercise needs to be a part of the medical treatment plan for people. It very rarely is, and that's one of our real core purposes in terms of how we work. So adding in exercise that complements, for example, any medication a patient is on is important. But the type of exercise then needs to take into account the nature of osteoarthritis. So we typically would look at exercises, particularly in a patient who's quite symptomatic and has pain levels. We certainly don't want it to exacerbate the pain. It can cause small increases in the initial stages of exercise, small increases in discomfort. But we really want to try and look at exercises that are low impact, but high on resistance. And that again is that strength factor. And there are a number of exercises that we can actually demonstrate now if you'd like to see some.
Okay, yeah, we'll do it. That'd be great. Thank you.
So in the first exercise, we're going to look at what seems like a straightforward, simple exercise, is how to stand up and sit down, but more effectively doing that, particularly off a low chair that may not have arms for support. So in the case of Eric, this is certainly a low chair, and Eric has arthritis in both knees. So sometimes we'll struggle either to stand up quickly without using the chair or sit down slowly. So what we're going to prompt Eric to do is to cross his arms across his chest. We're going to gently mimic some forward momentum. Eric's going to start speeding that up. He's going to rock faster forward. When he gets some momentum, he's going to go straight into that fast stand-up. So when you're ready, Eric, we're going to into that fast stand-up. The opposite on the way down, Eric's going to stick his bum and hips back, head forward, keep breathing, and slowly down into the seat. We're talking about a 4-second sit down and landing softly. So Eric did a brilliant job there. We're going to try 1 or 2 more repetitions. Fast up, a lot of momentum up. Slowly on the way down, you'll notice Eric's head and eye position is squatting forward, eyes on the floor. We're going to try 1 more. Momentum forward, fast up. Slowly on the way down, 4, 3, 2, 1, and a really soft, controlled sit down onto that deep seat. So well done, Eric. Okay, so the next exercise is something that is really commonly avoided because of pain levels or fear of causing further damage. So in this case, we're going to teach Eric how to kneel appropriately and safely and how to stand back up again. There is no indication, no matter how arthritic the presentation is in your knee, that kneeling is going to cause any further damage. It may be uncomfortable. The more we do it, the easier it becomes. Okay, Eric, I'm going to ask you to bring your hands down onto the chair. We're going to split your stance initially, and we're going to lower yourself to that back knee. Okay, well done. Now we're going to take some time on the knees. We just want to feel reassured that it's safe, it's appropriate. Take a couple of deep breaths in that position. Okay, we're not under any immediate threat here. And what we want to do now is try and lift one of those legs out to the side, and we're going to push up through the hands and that leading leg. We'll come back up into standing. There's a lot of work, Eric, being done there in the thigh muscles, the muscles back here in the glutes that are supportive of the knee and hip. Thanks. Okay, so this is an exercise that is at a slightly higher intensity. Mairead had hip surgery a number of years ago and is currently walking pain-free on a daily basis. We want to focus on rotation of the hip here. So I'm going to ask Mairead has got herself safely down onto the floor. She's going to slowly rotate to the side. We're looking to get as close as we can to a 90-degree angle on both legs, and then we're going to rotate back into that original position. In these two positions, we're getting internal and external rotation of both hips as we move, and we're strengthening an area that's typically not strengthened. So we're going to work on that again, just to repeat, Mairead, moving nice and slowly with control. Lovely hip rotation, involves some of the lower back as well for strength work, and back again. Well done, Mairead, that's super work. Lots of control and back around into that finished position. Thanks, Mairead, well done. So we've seen with Eric and Mairead slightly different presentations, a knee arthritic presentation and a hip post-surgery. So the key thing we looked at was doing slightly different exercise, and the point being, with arthritis, you can't have one exercise that fits all. In the case of Eric, we looked at strengthening muscles that support the knee, particularly his thigh muscles, getting up fast from the chair and sitting slowly down. That can be a real help to support his troublesome knee. In the case of Mairead, we looked at improving her hip rotation because she's currently walking long distances pain-free. She still wants to manage the performance of that hip, so we looked at something slightly different with floor rotations. The end message being there are different exercises for different people, but ultimately we have to try and get the right dosage and the right exercise prescription per person. So we want to encourage you to make sure you seek out information, get the right exercise for you, and progress from there. And best of luck with it.
Thanks, Andy, for that demonstration, and also thanks to Mairead and Eric for assisting you there. So moving on, many people will be familiar with the targets of, maybe 10,000 steps, a day, or 30 minutes of exercise 5 times a week. As you mentioned at the top of this interview, those have even changed, those guidelines. But for someone who's not currently undertaking any physical activity or exercise, that might seem really daunting. So what's the best way for somebody to start exercising when they haven't been doing so?
That is a tough question. I think there are a number of factors which cause people to have an avoidance of exercise. That's for all people, let alone people who have arthritis. I think there are a number of barriers. Enjoyment is clearly one, or not enjoying formal exercise in any way. But in the case of an arthritic patient, pain is a huge barrier, but then understanding what is the nature of the pain, why is the pain happening, and reassurance that exercise will not make it worse and you won't cause additional damage onto what's already there. In fact, exercise will reverse a lot of the negative effects of arthritis. Certainly, as you strengthen and as you gradually, in a very graduated way, if you've no exercise history and you're not doing anything at the moment, how you pace yourself and your entry to exercise is vital, because people with the best of intentions will finally drum up the motivation and courage to take on exercise and perhaps do too much. It has an adverse effect. It causes increased pain levels, decreases function, and that person unfortunately runs a mile away from the notion of ever doing exercise again.
Get disheartened.
Absolutely, yeah. And very understandably so. I find if we can work through in a logical way what is the pathophysiology of arthritis and help the patient understand what's actually going on in the joint, how best we can manage it, and how best we can manage it in lifestyle factors through exercise, diet, sleep, medication. All of the above play a role, but certainly exercise can be a significant barrier. I think that one of the key entry points is learning to pace yourself very gradually and only get very small gains initially and build up to that. One of the practical things I say to patients who are only starting with us in a clinical sense is, how are they walking up or down the stairs? Assuming they have stairs at home, if they do, if they can walk up the stairs relatively okay, that's good. Coming down the stairs, if they can do it quietly, that's a brilliant exercise to learn. A lot of people with knee or hip arthritis will move heavily and not gracefully on the stairs for fear of causing damage to the joint.
Yeah.
And a lot of the time, if we just coach them through that process to try and take weight through the joint and land softly, they're already exercising key muscle groups to help. So it doesn't have to be in a gym. It doesn't have to be with fancy equipment. It doesn't have to be in front of other people. It can be simply an exercise that you apply to your day-to-day life to get you started. And a lot of people find significant changes in function, even by managing that one area, as I've used as an illustration. If you can manage to go down the stairs facing frontwards and land softly, you've probably made a huge improvement to your overall joint function.
Okay, and then, you know, as somebody moves, you know, they get used to their exercise program, you know, how can a person stay motivated, you know, to continue that journey with exercise?
Yeah, I think one of the ways to stay motivated is actually having a finite target that you can achieve in a given week. I think consistency is difficult for us all, particularly if we're not naturally leaning towards exercise as an option. You know, for every age, there is a ideal target heart rate in the zones we discussed earlier. And moderate would be 60 to 75% of your maximum heart rate. Vigorous would be 70 to 85%. If you could achieve exercise that hits those areas in a week, you only need to do 60 to 70 minutes of that in a week. That can be divided up into 3 20s, 4 15s, and you're trying to make it attainable, but also trying to actually be precise. I think if a consultant cardiologist told you to take certain tablets, as many as you want, as often as you feel like, and you choose the milligrams, you wouldn't trust the cardiologist. I think exercise is quite underdosed, under-detailed in terms of guidelines, particularly for people with medical issues. But if we can say to an arthritic patient, you only need to do 60 minutes in your week, cumulatively, in the zone between 60 and 70% or 70 to 80%, and we can show them and work those figures out for them, and then show them the exercise that get them there, they get quite a sense of achievement because they realize they're hitting the targets they need to hit. They don't need to exercise excessively. Other than that, I would say really to try and find something that people enjoy, you certainly have to add in novelty, variation, try and manage it with a smile on your face, even if you have to force it at the start. But certainly the idea that there's a finite and appropriate amount, there's a prescription, there's a dosage there for people that they can use in their week, and that's all they need to do. If they may not get there initially, but they will get there with some guidance and with some coaching along the way and some experimentation around exercises that aggravate, some that don't. But again, there are small hurdles that are surmountable. And I think that idea of a finite amount of work within a certain zone that uses variation in your week makes it far more attainable for people. Compared to the visual a lot of us have with exercises in a loud gym, in an uncomfortable environment where people aren't aware that you're in pain and so on and so forth. I think we need to break down a lot of those barriers and images that we have that perhaps don't help our fear associated with exercise.
It can be quite intimidating, I suppose, for people as well.
Yeah, I think a lot of people are petrified by exercise, and it probably comes from our exposure to, a growing fitness industry and a growing industry worldwide around images of what fitness looks like. And I know from a clinical point of view, we work with people from, the average age of people we work with is 63, in all shapes and sizes with many other medical conditions. And that's the same across the board in the arthritic population. A lot of people would have other issues as well. So the one-size-fits-all idea of what exercise looks like probably doesn't help. And I think it's individualized. If we can get to that individualized prescription per person, which is very achievable, the barriers tend to fall away.
So we talked a little bit about, pain and osteoarthritis a little bit earlier on. I just want to come back to that. Many people that exercise sometimes believe that it's going to make their pain worse, or in fact might even make their arthritis worse. What would you say to people in response to that?
I think it's a true statement if you're doing inappropriate exercise. I think where a lot of people have encountered problems with arthritis and exercise is that they've tried maybe generic exercise. They've used somebody else's program. They've looked online. They've done exercises that weren't at the right dosage and weren't at the right intensity level, whether that's low intensity, moderate or high. But exercise done incorrectly in an arthritic population will cause increased pain levels. There are many patients and people out there with arthritis who've given this a try with the best of intentions, with a lot of courage, and trying to fight their way through pain. Correct exercise will not increase your pain levels. And if you are exercising and your pain levels are going up, you're doing the wrong exercise. It's not a case that exercise on the whole is bad for your pain or is bad for your arthritic joint. It's simply a case of getting the dosage of exercise right and finding the appropriate style and intervention of exercise. One thing we mentioned earlier that tends to repeat itself in the arthritic population, certainly in the knee, hip and spine, is to try and reduce the impact, the loading of the exercise, reducing the amount of jumps and reducing the amount of runs and walks, for example, and actually reducing impact in the joint, but increasing resistance and strength training in the muscles around the joint. So an example, around improving joint function without causing any changes in your pain experience. And over time, as the soft tissue structures around the joint become stronger, we tend to see a fall off in those pain levels. And we actually see an increase in circulation around the joint and the overall joint performance. But it tends to start with lower impact exercises and higher resistance, higher strength, higher than a lot of people would start with at times, which they may feel safe or unsafe. But we have people in their 70s who are using dumbbells up to 8 to 10 kilos, 12 kilos as they squat with arthritis, but they didn't start there. They built up to it.
I mean, a question we often get asked is, how much can a person do? And, I suppose when would you know when you've done too much?
Yeah, and again, it's very difficult to gauge if you're not familiar with it. I think in very plain language, if your pain levels have increased in or around the arthritic joint, you've done too much. Very, very simply. If you have muscle soreness, that is not the same, and that is something that we really try and embrace. I know as a physiotherapist, lots of times patients will refer to us as physiotherapists because we enjoy
Heard that.
we enjoy the idea that a patient has muscle soreness. And the reason we enjoy it, apart for the patient's benefit, is we know they're doing the appropriate amount of work in the soft tissues, the muscle, the ligament, the tendon around the joint. And you will get muscle soreness, and it will last for 24, 48, sometimes 72 hours. But certainly when I've asked people to give me their gut response, is this a good soreness or bad soreness? They know, and people will say, no, okay, it's not pleasant, but it's a different soreness to the joint pain I have. And we've to really try and spend time on that, because pain is a subjective experience for people, and how we describe pain is different from person to person. So when people start to negotiate their way through that and understand that, yes, this is soreness, but a different type of soreness in the muscle, and actually my joint pain has stayed the same or got a little better, you tend to get huge buy-in, and you tend to get huge motivation and bursts of motivation. And that leads to other challenges, because people then try and capitalize on feeling better and overdo it again. So there is a kind of a constant thread running through any inflammatory condition. An inflammatory condition fluctuates. It never gets better in a straight line upwards. It doesn't get worse in a straight line downwards. And if we can fluctuate with our response to exercise and understand sometimes the response is different to others, but we haven't done significant harm. In fact, in most cases, we haven't done any harm to the joint. But yeah, increases in joint pain, if we can differentiate between that and muscle soreness, increases in joint pain is a really clear signal you've done the wrong exercise, or you've done too much of the right exercise.
But muscle pain is it's really showing it's working. You know,
Absolutely.
you're really engaging muscles you haven't engaged ever,
I mean,
or in a long time.
Yeah, I mean, again, I sometimes refer to certain age groups or populations. In my mind, there's a chronic underdosage of exercise in the older population. The idea that, toe taps, rolling shoulders is going to strengthen anything, particularly in an arthritic population, is an underdosage. There's scope for people to get medicated appropriately, but at high dosages. They don't. If it requires a high dosage in medication, it will be used. Sometimes a high dosage in exercise is appropriate, regardless of age or regardless of presentation. And exercise can very often, in this demographic, in an arthritic population, can be underdosed. And again, that example I used, we've people in their 70s and 80s who are using significantly heavy weights to stand up from a chair and sit down, and not causing any damage. Again, now they've responsibly built up to that, but yeah, I mean the sense that we can get an appropriate overall dosage again is something that's really relevant for this population.
So what I'm hearing you say there as well, about the dosage, it sounds like it is very individual. I think sometimes we might run foul of looking at people with osteoarthritis as a homogenous group, and they're not, of course.
Absolutely.
Are there types of exercise that you wouldn't recommend for people with osteoarthritis? You mentioned some of the kind of high impact exercise there.
Yeah, I think as a general rule, anything that is high impact involves jumping, loading of the joints. Certainly to start with, if you're starting off with exercise, that's something that will antagonize an inflamed or arthritic joint. So an example might be, squat jumps as opposed to squats, star jumps. Again, there are countless thousands of generic exercise videos on YouTube, all around the internet, but a lot of them will be geared towards a population that doesn't have a underlying joint issue. So if we asked 1,000 people to described to us what exercise looks like, I wonder how many would include the idea of jumping and moving fast and moving vigorously. Exercise can be slow, exercise can be quiet, exercise can be drawn out in slow and controlled periods, but raise the heart rate and not be impactful on the joint. So I think I fully agree, Gráinne, in that it's very hard to give a wide-ranging prescription that fits for everyone, because we're all different in our presentation. But I think as a general rule, yes, avoidance of higher impact loading of the joint. So, trying to jog your way better when you have an arthritic or inflamed joint. I see it again with a lot of people who desperately try to walk their way better.
Yeah, I was going to ask you about walking, because that's something you would see a lot of people doing, and they say, well, maybe they have pain in their hip or a knee,
yes,
but it's sort of, I need to keep walking.
Yeah, and I have lots of medical friends who don't work in the area of exercise prescription that I have heated debates with, where if they're not sure how to prescribe exercise, they might say to their patient, look, just go for a walk and take it from there. But in an arthritic population, particularly when the joint, the knee or hip is flared up, going for a walk is not the answer. You can't, if it's sore to walk, you can't outwalk it. It will not improve from further walking. And what we tend to see is people trying their best, and I can't even walk, I can't do anything. So then they abandon ship, and it's a really frustrating process for the person, and it's certainly a frustrating process to see from a clinical environment when I suppose when we understand what can be done to help. Our job then is, the job of all people who work with arthritis, is to understand the benefits of how exercise can be used as an intervention, for example, without walking. And walking may not be categorized as high impact, but it's certainly impactful on a joint. We often find people who have arthritic pain while walking will go through a period where the joint actually warms up during the exercise, and they think, maybe I'm improving. And then once they sit down and rest and watch TV and have dinner, and the joint starts to react to the exercise, and you get swelling and redness and heat and night pain, and they get a very, very sore reminder that maybe I shouldn't have done that walk. And I think people get quite despondent in that situation, and I certainly empathize with that. But we certainly can't walk our way out of an arthritic flare-up. We can strengthen our way out of it with low impact exercise, and we can recover function in order to get back walking. And we can get back walking relatively pain-free over long distances again, once we take a break, do the right type of exercise, and then get back out there. I'm really keen for people to get back and do the things they love. If that's walking, that's the great outdoors. Exercise is not a replacement for that. It's actually a conduit. It's a route to getting back to do that.
I think people watching will find that really helpful, just how you've explained that.
Okay, well, hopefully. It's a difficult area. I think a lot of people feel misunderstood because the pain levels are difficult and the apparent levels of function seem so compromised. So yeah, I mean, hopefully we can keep it simple and people can get some benefit. Yeah. And,
just how best can a person incorporate exercise into their daily life?
My sense of it, without being overly simplistic, is to take a deep breath and start something, just to start and understand one or two exercises that are safe and appropriate. Start them and maybe think about 5 to 10 minutes in a day, and making it part of your day, the same way we shower, the same way we wash our teeth, dress, have breakfast. Make it a part of our routine. Try and reduce the fear around it. Fear and avoidance in any walk of life, in any of our pursuits, tends to not be a good strategy. I think fear and avoidance, if there's fear there around exercise, we can explore and investigate, and we can be taught, or we can learn for ourselves. There's lots of information that's accessible out there. We can learn what is appropriate and understand that the fear, while the fear is real, that we need to try and surmount it by addressing it. I think the fear, which can lead to avoidance, will not help an arthritic patient. Similarly, lifestyle changes have much the same impact, sleep and diet, but they're not my areas of expertise. But certainly, to coin the phrase of, I think it's Nike, is it just do it, or you just start in without causing that high impact kind of increased pain level. So even if you start something small and measure it a couple of minutes a day and monitor your response to that, more often than not, your response that you monitor will see small improvements in function as opposed to disimprovements. And that alone is a nice starting point where we can build from.
So the message is start small and build up from
absolutely
there. Yeah.
And again, I think it doesn't matter how small the start is. If the start is standing up better from the chair, or trying to stand up without using our arms, or how small that is, if it's learning to walk down the stairs more quietly, that's an exercise, and that's a starting point that we can incorporate into our day and monitor our response to that. And what happens is it tends to grow legs and build momentum. As soon as there are small changes, we can build from that. But like in any scenario, if we avoid it completely, it's going to be problematic.
Moving on now to the subject of surgery. Surgery sometimes does become a feature of life for people living with osteoarthritis. So, for someone who's recovering from surgery, what should they do?
Post-surgery can be daunting. I worked in various hospitals where I sat on the edge of the bed and the patient was being discharged and I suppose the patient was vulnerable. And so what do I do now? I've had my surgery, I'm on my crutches, my knee looks big, or my hip scar is covered. How do I manage on my own? And it can be a daunting experience. I think typically after surgery, there are initial stage exercises that everyone will be well versed with from their hospital stay. What I would urge is that people give those a go, but only for 10 days, 2 weeks. At that stage, when we start to improve function, we need to change the exercise to further improve function. So I would encourage people, I think the wider audience who've had surgery will often feel they got an initial piece of advice that worked fine to get them out of immediate trouble. And after that, they were a little bit abandoned and they felt they were on their own. I'm not quite sure what I need to do to progress. How do I get back to playing golf? How do I get back to walking? How do I get to do the things I want to do? In that case, again, it's about changing the exercise prescription to more suitable challenges. In order, we can't get to a stage of climbing the stairs if we can't climb one step, and we literally have to build it that way. But the initial stage exercises after surgery are exactly that. They're basic initial exercises and they don't facilitate a full recovery. So I think it's really important distinction to make for people the joint mobility type exercise where you improve the bend in your knee or you improve the movement around your hip. They are very, very early stage exercises that are designed to help the first 2 weeks of recovery. And if you're doing them after 6 weeks of recovery, you're not improving. And again, maintenance of the same exercise.
You need to change it up.
Yeah, absolutely. You need to increase the challenge appropriately. And a lot of people won't be aware, I suppose, what that exercise is. But again, if they seek the advice of a physiotherapist, for example, they'll certainly get guided towards the stages. And we would have protocols and stages where we can measure and intervene and progress as appropriate, or regress if the patient is having complications after surgery, which is often the case. But the idea that there is a one-page document with 3 drawings of a stick man doing a knee and hip exercise, it doesn't work after 2 weeks. We need to progress after that.
Okay, I think that'll be really helpful, again, for people watching. Lastly, what would be your top piece of advice to anybody who's watching, who's having a tough time at the moment with their arthritis?
I think my main piece of advice is that if they're having a tough time with arthritis, it's not a terminal sentence. It won't always be like this, no matter how it feels, if they get the right coaching, if they get the right guidance. And I think that is out there. It's that level of knowledge and expertise in the healthcare profession to help this condition is vast. I think for people who are having a tough time is to really understand that they're not alone, and the pain levels and the level of dysfunction can change, and it can change relatively quickly. So I think there's huge hope for people who are struggling. I'd love to reassure them more and give them greater motivation, because I suppose I've seen it happen in so many cases, and it's not because of me or what we do. It's simply because the process done correctly and the patient being determined. That is an important factor, and it helps. But even if they're exasperated and they've lost hope, if they can hang in there and get started with some kind of improvement around joint function, however small, it can build and snowball from there. So yeah, I mean, it's a tough station, but it's not a terminal sentence in any way. It's a difficult condition to deal with at times, and it does fluctuate, but certainly there is scope to have significant improvement in function regardless of your arthritic status.
Okay, thank you.
Thank you.
Thank you very much, Andy Dunne.
Thanks, Gráinne.
And thank you very much to everybody watching this video. You'll find lots of information about physical activity, exercise and arthritis on our website, arthritisireland.ie, and we also have dedicated support groups on Facebook. You can also contact our helpline on 0818 252 846. And lastly, thanks to Andy Dunne for sharing his insights and expertise in this area. It's been a real pleasure speaking with you, Andy.
Thanks, Gráinne.